Good evening. On behalf of the Sri Lanka College of Psychiatrists, let me introduce you and welcome you all to this edition of the College Lecture Series. We have an extremely eminent speaker, Dr. Daniel Maughan, sharing his experience on diagnostic issues in early intervention in psychosis. Dr. Daniel Maughan is an early intervention in psychosis consultant in Oxford, medical lead for Oxford Healthcare Improvement and honorary member of Oxford University Department of Psychiatry. He will discuss the concept of a trans-diagnostic model of psychosis, diagnostic boundaries, how to differentiate psychosis from other conditions such as autistic spectrum conditions and personality disorders. Let me also thank Dr. Suhashini Ratnatunga for arranging for Dr. Maughan to speak today. Over to you, Dr. Maughan.
Well, thank you very much for having me, and certainly a delight to have been invited by Suhashini, who we worked together in Oxford a few years ago, and we were very sad to lose her in Oxford, but our loss was your gain over in Sri Lanka. So yeah, it's a delight to be here with you in your evening in Sri Lanka. And just say before I start, I'm aware of the news in Sri Lanka, and I'm very sorry that you're going through such difficult times, and it makes your presence here this evening listening to my lecture all the more important, given all the stresses you must be going through. So thank you for coming to listen to this lecture in diagnostics in psychosis. So yes, I'm the consultant psychiatrist for the early intervention in psychosis service here in Oxfordshire, and I'm involved in research in this area too, and I would like to spend the next sort of perhaps 30-40 minutes talking to you about really a clinician's perspective. This is a doctor's perspective on the diagnostic complexity of these presentations of potential psychosis. And I think it's possibly the most complex area of diagnostics in psychiatry at the moment. The potential for different diagnoses are very, present. The psychosis can look like lots of different things, and lots of other diagnoses can look like psychosis. And we're dealing with symptoms we are more and more aware are not specific to psychosis as well. And so I think whilst I don't feel like I'm at the end of my journey in fully understanding exactly how to tease these presentations apart, I hope to be able to give you some of my insights around diagnosis in this area. So I'm going to start telling you a bit about what early intervention in psychosis is. I don't know whether you have it in Sri Lanka, but this is a bespoke service for people with first episode psychosis, for FEP. And the idea behind this bespoke service was that we have a range of evidence-based treatments, which you can see here on this slide, that we bring together and offer to every patient who has first episode psychosis. And we have them for 3 years. And the idea is that we act early, we offer them the full spectrum of evidence-based treatments, and we really work hard at improving their insight so that we can improve their long-term prognosis. So what are those evidence-based treatments? These all come from the NICE guidance at the National Institute for Health and Clinical Excellence we have here in the UK. I'm sure you're aware of the guidance that they provide. And these treatments include CBT for psychosis, physical health assessments, as we know that antipsychotics can cause a range of physical health problems, as indeed do psychotic problems. Family interventions, we offer behavioural family therapy, specifically for those families that have high expressed emotions, but we offer it across the board, and that has really good evidence for reducing relapse in psychosis. We offer wellbeing support around smoking, physical activity, healthy living. We offer walking interventions. We have a climbing group. People can climb. We have sports groups, and we offer a range of different options that young people might be interested in being involved with. We are really, really focused on getting to clozapine quickly. If there's treatment-resistant schizophrenia that we spot, we really need to get there quickly. We don't want to spend years getting there. We want to get there in a year if we can. And that means really working hard and assertively with people and watching closely. We have carer support workers who work with families, and we have employment specialists to help people get back into jobs. So that's what our service looks like. Here in Oxfordshire, we have a population of, I don't know, maybe 150,000 or something like that. And we have a service just for first episode psychosis patients, and the staff we have are about 30. So it's a bit more of a supported team than your standard mental health services, so we can work a bit more assertively with these patients. So we take people who have had a first episode psychosis. The psychotic symptoms should have been over 1 week, but occurring for less than 3 years. And they have to be between the age of 14 and 65. We don't take people who have organic psychosis, for example, after a stroke, or if it's been substance induced, clearly by maybe an amphetamine like cocaine or MDMA or LSD perhaps, or if it's been a medication like steroids. DUP stands for duration of untreated psychosis. So if the DUP, if the duration of psychosis has been over 3 years, we don't take them. And we don't take them if they'd had a previous treatment with an antipsychotic. So why do we have EIP services? Why early intervention in psychosis, not early intervention in depression or OCD? Well, there is this theory that deterioration in psychotic conditions occurs aggressively in the first 2 to 3 years, and that there are critical factors like understanding their condition, like their relationship to services, their relationships with their family, that are really important. That if we can act in that moment to improve their insight before the delusions have become entrenched, that we can really get them to understand their problem, engage with treatment, and improve their long-term prognosis. And so what we're dealing with here is secondary prevention. And I'll go on to talk about the holy grail of primary prevention, but really in early intervention, we're dealing with people who've already developed first episode psychosis. They've already developed psychosis. We're trying to stop it happening again. So that's secondary prevention. The evidence for EIP early intervention is strong. For the first, after 1 and 2 years, in the longest and largest RCT in Denmark, with good numbers, 547 people, the global assessment of functioning and symptom scores were significantly improved. But the trouble is, after you leave early intervention, the improvement reduces back down to standard care. So there are discussions about whether we should increase the duration of early intervention to 5 years, and there are studies happening in that at the moment. So people with under EIP, 16% more likely to gain employment, 50% more likely to get into a house, and 17% more likely to have a sense of well-being than being in general services. And if you look at a really wide cost economic analysis of early intervention, there's big savings to be had, mainly through lost productivity, so people being out of work. So because early intervention gets people back into work quicker, we can save society a lot of money. So yeah, we in early intervention, we recognize that people who have a first episode psychosis don't necessarily have one of the 2 primary psychotic conditions, namely schizophrenia or bipolar. Somebody might have psychosis for a different reason. 30 to 40% of people who have first episode psychosis don't go on to have another psychotic episode. Therefore, it's unlikely, isn't it, that people who have FEP all have bipolar and schizophrenia, which are relapsing, remitting, long-term conditions, right? So we recognize that psychosis can happen in other conditions. And of course, we all recognize in psychiatry that you can have depression with psychotic symptoms. But we broaden that out, and we recognize that people can, the obsessions in OCD can become delusional. The re-experiencing phenomena in PTSD can reach the severity of hallucinatory experiences equivalent to that of schizophrenia, where people believe they're back in that traumatic space. And there are all sorts of other mental health conditions that people can have that can lead to psychosis. So in another sense, psychosis is a marker of severity. And whilst in EIP, yes, we are trying to spot those people with schizophrenia and bipolar, who we are really trying to improve their long-term trajectory. We are also looking to address these other patients who might not have those psychotic conditions, but might go on to have very severe forms of mental illness if not addressed early. So we recognize that psychosis is a transdiagnostic concept. And just because somebody has a psychosis does not mean it necessarily is schizophrenia or bipolar with manic symptoms with psychotic symptoms. And that's important because that has implications in clinical practice. So somebody might be sectioned to hospital, they might be psychotic. We don't say they've got schizophrenia, and we don't assume lifelong treatment. We say you've had a period of psychosis, we want to treat you with antipsychotics for maybe a year, maybe two, depending on the patient characteristics, but that we might try to stop the antipsychotic if there's a good period of stability and see if they really do need that long-term antipsychotic or mood stabilizing treatment. And that's really important because actually, you know, there's going to be a good third of people who aren't going to need that treatment. And so we mustn't jump to conclusions necessarily. And one of our jobs, I think, as early intervention psychiatrists is, after they've had a psychotic episode, to really do a thorough evaluation when they're well to see if there's any underlying conditions that might have exacerbated psychosis. So it could be that they've got undiagnosed OCD or undiagnosed depression or undiagnosed PTSD. But if we treat that, then their likelihood of getting psychosis again is very minimal. And then we need to treat that very thoroughly in order to best prevent future episodes. So now let me get on to a really interesting phenomenon, one that really grabbed me when I started in early intervention psychosis, that of the at-risk mental state. This is the prodromal phase of psychosis. So it's generally understood and accepted in literature that people do not turn psychotic like this, okay? They develop these problems slowly over time. And that if we can spot those problems, then we can potentially stop that person developing first episode psychosis. So primary prevention, the holy grail of psychiatry. And so we do an assessment for this. And these are the three groups of the at-risk mental state. In other countries, in America, for example, it's called the ultra high risk group, UHR. We call it ARMS, at-risk mental state. And so there's a vulnerability group who have a first degree relative with psychosis or schizotypal PD, personality disorder, and a drop in social or occupational functioning. That's the SOFAS scale, a really good scale. If you're thinking diagnostically, is this psychosis? Always check functioning. That's the vulnerability group. Then we have the attenuated psychosis group, which don't have full threshold psychosis, so they might have some paranoid thoughts, but it's not delusional. And then you have the blips group, brief, limited, intermittent psychosis, so fully psychotic, less than a week. These are the three groups of the at-risk mental state that my colleague, Dr. Cooper, is now going to tell you a bit more about. So over to you, Dr. Cooper.
Hi there, everyone. Thank you for joining us on your evening, our afternoon. My name is Heidi. We are a CALMS-informed service. So at the Early Intervention Service, we use the CALMS, which is the Comprehensive Assessment of At-Risk Mental States. And that's made up of a range of subscales that look at different areas of psychopathology. You would then go and rate within each subscale to aid decision-making to determine if a patient meets the symptom threshold for either a psychotic episode or an at-risk mental state. So as Dr. Maughan said, there are two arms. There's two arms of the ARMS category: an attenuated psychotic state or a period of brief limited psychotic symptoms. An attenuated psychotic state is where symptoms do not meet the threshold for a psychotic episode as they are not severe enough to require treatment. A brief limited psychotic episode, or a blip, would be symptoms meeting the severity threshold for psychosis, but lasting less than 7 days and resolving without medication. We use an abbreviated version of CALMS, which is more clinically efficient and includes the areas that are used to identify the at-risk mental state, attenuated symptoms and blips, but the full version actually has 7 domains. The sections, sorry about that. The sections that we assess against are unusual thought content, non-bizarre ideas, and perceptual abnormalities. There are other sections related to disorganized speech, aggressive behavior, suicidality, and functioning, so the SOFAS. So this is unusual thought content, which includes delusional mood and perplexity, bizarre ideas such as thought insertion, withdrawal, and broadcast, and ideas of rest frames. If a patient's experiencing a psychotic episode, then their symptoms will be rated as 6. An example of this would be a patient who believes they are receiving messages through the television with 100% conviction, and the belief cannot be shifted despite evidence to the contrary. The difference between a 5 and a 6 would be if the patient's able to question that belief at times, but it still resulted in behaviour change, albeit a more minor change than those scoring a 6. So someone watching less TV would be a 5 versus getting rid of their television would be a 6. The non-bizarre ideas section contains persecutory, nihilistic, religious, grandiose, and somatic ideas, as well as ideas of guilt. As with the previous section, the symptoms of a psychotic episode would be rated as a 6. An example of this may be a patient believing they're being followed and targeted by the mafia, held with 100% conviction that cannot be shifted. The difference between a 5 or a 6 would relate to whether they can question these beliefs and the impact on their behaviour as before. An example may be that the patient would sometimes walk a different route home, which would be a 5, versus calling the police and asking to be put in witness protection, which would be a 6. And if you aren't sure if this could be real, then you can always ask the patient's family or friends whether it's appropriate for their situation. Perceptual disturbances include hallucinations, distortions, and delusions in all sensory modalities, as well as somatic changes. For a diagnosis of a psychotic episode, a patient would need to score a 5 or a 6. For example, auditory hallucinations believed to be true at the time and afterwards that are very distressing for the patient. The difference between the 4 and a 5 and 6 would be that the patient is able to give an explanation for these experiences, and the intensity and character of the hallucinations is lessened. So occasionally hearing their name being called would be a 4 versus the continuous running commentary, which would be a 6. Further to this, for each section, the patient must meet a criteria for frequency of symptoms, which for a psychotic episode would be a 4 or more. So a score of 4, patient will be experiencing symptoms at least 3 to 6 times a week for longer than an hour at each time, or daily for less than an hour on each occasion. A patient would need to score a 6 on unusual thoughts, plus minus and or non-bizarre ideas, and or a 5 or a 6 on perceptual abnormalities, as well as meeting the threshold for symptoms and frequency lasting longer than a week. Therefore, you can see the importance of asking very specifically about frequency and intensity of symptoms, as if you were to briefly screen, you could very easily end up starting someone on antipsychotics who doesn't need them and causing possible iatrogenic harm. Dr. Maughan.
Thank you. So you can see that our assessment for psychosis is really quite thorough. We really do nail down, if you're having a delusion, how often are you thinking about it? How much does it distress you? And, is it in the day? Is it in the night? If you're hearing a voice, it's not just, yes, they're hearing voices, tick. It's, what's your explanation of it? How often are you experiencing it? For 2 seconds every minute, or for 5 minutes every hour, or throughout the day, but perhaps you're having some breaks. So we really try and get a lot of detail around the experiences and really question the rationale and almost try and get some sense of insight. So whilst we do have a pathway for those with an at-risk mental state, there are problems with this holy grail, this primary prevention idea. It's not as easy as just spotting and classifying at-risk mental state and then stopping first episode psychosis happening. Let me tell you a bit about that. So first of all, there's 2 different categories, and the blips category is much more likely to tip into first episode psychosis than the attenuated syndrome, where you've just got low threshold symptoms in the attenuated syndrome. And so I'm a lot less convinced about whether we should actually follow up the attenuated syndrome. And that's partly because so many of the symptoms are really non-specific. So they're hearing a bit of a voice, but not very much. They've got some paranoid thinking. The potential for other diagnoses there is very high, and the potential that it might go on psychosis is really quite low. There's a problem with the heterogeneity of the prodrome of psychosis. So the theory behind the at-risk mental state is the people who go on to develop first episode of psychosis just have the same symptoms, but either less intense or last less long. But we know that's not really the case. And actually, a lot more people who develop FEP, first episode psychosis, actually have depressive and anxiety disorders first, before they go on to develop first episode psychosis. And this at-risk mental state wouldn't capture those people. There's a real lack of specificity in the at-risk mental state. And you can take people into the at-risk mental state category who really just have another problem. And that's then when you get into that sort of dilemma, there's a real problem of having increasing numbers of people who don't yet really have a diagnosis, because the at-risk mental state is not a diagnosis, it's a prodromal academic construct at best. You're managing people with high numbers of people when you don't necessarily even have enough funding for the first episode psychosis service. So there becomes a bit of a problem there. The evidence base for interventions in the at-risk mental state is not great either. There's some evidence for CBT, there's no evidence for antipsychotics. The suggestion is that you should signpost. So if somebody's using drugs, stop using drugs. If somebody isn't sleeping well, help their sleep. If somebody's depressed, treat the depression. That's as far as it goes, really. There's no conclusive evidence that you can really treat these people and avoid transition to FEP. And that's really the crux for me about measuring this, and the basis for the at-risk mental state is that how do you know when you've averted somebody from having first episode psychosis? So you've spotted the at-risk mental state, you've treated them with CBT, and they don't develop FEP. Well, how do you know whether they would or not? And that's a real dilemma in the academic research about false positives. So we've got a good result, but have we? Would they have transitioned? We don't know. And you need really large studies to be able to determine that, which haven't yet happened. And then more research has come out showing that the prognostic accuracy of the CALMs, it initially was thought to be really very good. But now it's thought that the specificity for trying to work out whether somebody is at-risk mental state or not is really quite poor. So the idea is that we really do need to learn a bit more about this at-risk mental state before we can really start acting confidently in the clinical arena. at the moment, it's helpful to spot, to do some signposting. Can we do more than that? Perhaps not. So they've got a 16% risk of developing psychosis in 2 years. That's lower than 29%, which was initially reported in the literature. So let me get on to perhaps the crux of this talk. I've told you about my team and how we work, who we accept, why we have early intervention services. I've told you about the at-risk mental state, why it's a really exciting area to work in for going primary preventative work, but it also has its dilemmas in practice. So let's get on to the crux of talking about these diagnostic difficulties in psychosis. So first of all, if you're dealing with an adolescent population, there's many people who have psychotic-like experiences in adolescent populations, and I'll get on to talk about that more. But that's probably a headline that I would say, if there's something we need to be really aware of in early intervention, is that loads of teenagers have psychotic-like experiences that aren't psychosis. But actually other conditions in adult populations can present with psychotic-like experiences. So people with ASD, autistic spectrum disorder, have voices and paranoia. People with post-traumatic stress disorder have re-experiencing phenomena. People with OCD have bizarre obsessions or intense imagery. And we know people with personality disorder have all sorts of unusual experiences, like voices and paranoia in borderline. They can have paranoid thoughts in paranoid personality disorder. And people with schizotypal, yes, they can have all sorts of strange beliefs. And then we have the organic presentations. So whilst in EIP, we might accept somebody with OCD who is fully psychotic, there are also people with OCD who look like they're psychotic, but actually it's just related to the OCD, or it's related to another condition. So whilst we're trying to really accept and care for people who meet the criteria for psychosis, we're also trying to be really careful that we don't label things as psychosis which aren't. If you look at the history of psychiatry, back about 100 years ago, we only had one diagnosis, didn't we? And that was dementia precox, which turned into schizophrenia. Throughout the history of psychiatry, we have cleaved off different presentations that we recognize aren't psychosis, aren't schizophrenia anymore. The first one was bipolar. And then we had shell shock, which turned into PTSD. Then we had depression. We've slowly cleaved presentations off, taken them away from schizophrenia, recognizing that they're not actually schizophrenia. That's been our history, our development over the past 100 years. And we are still doing this today. And if there are two diagnoses that we still kind of get wrong and calling schizophrenia or psychosis, which isn't, it's autistic spectrum disorder and borderline personality disorder, or sometimes the comorbid presentation of both borderline EUPD and ASD. So I'm going to talk a bit about ASD particularly, as I think that's the one we get more often wrong. So people with autistic spectrum disorder, they hear voices, okay? That's a common experience in ASD. They can hear, smell, and feel things more acutely, and often talk about their experiences more vividly, which can make it seem as though it's a hallucinatory experience. They express their thoughts in an unusual or concrete way. They might say, "My brain told me to do it." They might struggle to understand their emotional world such that when they feel happy, it can feel like somebody else is feeling happy, or somebody else has put that emotion onto them. They can struggle to understand their internal thinking or conversations we all have in our inner monologue when we have a disagreement. You know, I want to have that piece of cake, but I'm on a diet. Oh, but I really want that cake. Oh, but I'm on a diet. We're quite good at holding that disagreement in our heads. People with ASD, they struggle with that, and it can often be a dissociated experience of having a disagreement. within themselves. So people with ASD have a really rich internal world, a really strong, powerful imagination. And it can be really difficult to disentangle for them. If they've watched a TV program, was it real? Was it not? They're imagining themselves in the TV program, or they're imagining themselves playing with their cuddly toys, or, you know, they might be just reliving events that have happened that day that can seem real and in the moment. And so that can be quite difficult to disentangle, because they're saying, oh, I'm hearing the person I was working with earlier today. Are they actually hearing it, or are they reliving a memory very vividly? They can use self-talk as a calming strategy. So they can talk to themselves. So it can look to a family or relative like they are talking to themselves or hearing a voice. And how they present when they experience an emotion can be very extreme. And it can also, the people with ASD will often present with alexithymia. They don't understand their emotions. So when they're feeling angry, it's almost like they're not themselves when they're angry, and somebody else has put either that anger onto them, or that they're somebody else when they're angry. And that can be quite difficult to disentangle. Often when they're angry, they think, I want to hit that person. But because they don't understand that as an angry emotion, they might see that thought as something external. People with ASD can develop paranoid ways of thinking. They're often bullied. They have poor theory of mind, so they can't understand what other people are talking about, or what, you know, or how they're feeling. So they don't fit in. They don't feel comfortable. They don't laugh when other people laugh because they don't understand social cues. They don't understand jokes a lot of the time. So you can really develop paranoid ways of thinking. So ASD is a really tough nut. And what I found the important thing to be aware of is, first of all, that most importantly, hallucinatory experiences are not specific to psychosis. They happen a lot in ASD. They happen a lot in borderline. They happen a lot in the general public as well, actually, and they're just not pathological. So we must stop thinking that hallucinations, or the experience of hearing a voice, is specifically a psychotic experience. We must also be aware that people with ASD might initially sound, I remember this one patient said, oh yeah, somebody's putting, I'm able to tell what other people are thinking. That's what they said. And that they just came out with it. I can tell what other people are thinking. And then actually, the more you explore that, actually it's not a delusion. What they're trying to explain is that their mum can get cross with them, and they know that their mum's cross with them because they're wagging a finger or something like that. So you find on further exploration of that statement that sounds exactly like a delusion, kind of crumbles away and isn't there on further exploration. The other critical thing I've noticed is looking for triggers. People with ASD, we know, love routine. And often there's a change in routine, whether relationally or occupationally, educationally, that something's changed and the trigger has caused the presentation, rather than necessarily what you might typically see in psychosis, which is much more of a prodrome, a reduction in functioning, a reduction in social withdrawal, poor, this whole poor concentration, dysexecutive syndrome. You'd see that in psychosis. In ASD, you might see the trigger, and then suddenly the voices start, more paranoia, these things. So it's a different presentation. And so these are things to look for. And the other critical bit is functioning. So what you might find is that somebody with ASD might not function very well, but they might develop voices and paranoia, but the functioning stays the same. But surely if somebody has developed a psychotic condition, their functioning shouldn't be the same as it always has been, should it? Their functioning should deteriorate. That's why we use the SOFAS, the Social and Occupational Functioning Assessment Scale, SOFAS. And we say you have to have a reduction of 30 points on that if we're going to accept you in psychosis, with the premise that psychosis should be affecting functioning. And there's probably another diagnostic reason if they're having these experiences, if their functioning is still the same as it's always been. The diagnostic problems get worse, more problematic in adolescent presentations. So developmental issues, people with ASD in adolescent populations have even more of a strong imagination, and they struggle even more to present themselves and discuss their internal world. And they're poorer historians, they're more easily led, they're more likely to say yes to your questions. This is an interesting graph for me, because if you look at the age of onset schizophrenia, and if you look at, there's nothing at 12 to 14. At 15 to 19, that's 4 years, you've got about 10%, about 8% maybe for males and about maybe 5% for females. But in my clinical experience, that's all in ages 18 and 19. Very, very, very little of that is in 15 and 16-year-olds. Most of it is crammed into 17, 18, 19. So if you get a 15 or 16-year-old presenting, you need to be aware that this is rare. If they've got psychotic-like experiences, it's much more likely that it's not going to be psychosis than is going to be psychosis. And indeed, we see that in the prevalence of onset schizophrenia is much more above 19, not in adolescent populations. They've done general surveys of adolescents looking for psychotic-like symptoms, and people aged 9 to 12, 17% of them, if the general population aged 9 to 12, will say that they have psychotic-like symptoms. And adolescents 13 to 18, 7.5%. That might be hearing a voice, thinking they're being followed on the way home, thinking they're seeing a shadow, thinking they're being watched in the shower, these things. And if you compare that to the prevalence of schizophrenia, 0.5 to 1%, or bipolar 1 to 1.5%, 1 to 1.5%, they're a lot lower. So there's most people you can see in the adolescent category who have psychotic-like symptoms do not have schizophrenia. So that's important to recognize. Even up to 18, 7.5% of people having psychotic-like experiences, whereas we know it's much more like 1%. So that's going to be 7, for every 7.5, 7 to 8% people you're seeing with these experiences, maybe only one of them might have actual psychosis. Voice hearing, 10,000 people surveyed of 16 to 19-year-olds, 10% heard a voice, 5% were troubled by a voice. So we've got to say most of those people do not have psychosis, they've got a different diagnosis. And this is the way that I think about voice hearing, which I think we need to get away from thinking specifically hallucinatory experiences are really not specific to psychosis. Non-pathological voice hearing happens. Most voice hearing that happens, my clinical impression, is due to emotional processing problems. But it can also happen in depression, PTSD, and ASD. And there is a small proportion of people who have psychosis who hear voices too. Yes, of course we know that, but the majority of people who hear voices do not have psychosis. And the way I look at, if you look at this biggest circle there of emotional processing, why do they hear a voice? Well, the way I think about it is that if you've been traumatized at an early age, you've been abused as a child, you've learned to cut off that difficult emotion. You've learned to hide it behind a door, or in Freudian terms, you repress the emotion. But we all know as psychiatrists, if you have an emotion, you experience an emotion. If you don't express it, then it'll come out in another way. And indeed, we see that in the voices can come out as dissociated dissociated ego states, where suddenly the emotion is overwhelming and can be experienced as a voice. And that's how I understand what's happening in borderline personality disorder. In an autistic spectrum disorder, it's a similar process as well, because often they're alexithymic, they don't understand their emotions. So how do they express their emotions if they don't even recognize they're in an emotional state? And that's the difference between borderline voices and ASD voices. People with ASD voices might have a happy voice, and they might have an angry voice, and they might have a sad voice, they might have a comforting voice. With people with borderline, you tend to only get the hateful voices who say, kill yourself, I hate you. And that's because they're locking away an emotional trauma that's presenting itself. Whereas in ASD, it's all the range of emotions that they're not processing that are experienced in a dissociative way. So what should we actually look out for? If we shouldn't look for voices, and there's all these problems, we look for paranoid delusions, really fixed delusions that affect behaviors. If you've got a delusion, it will start affecting your behavior. You'll stop going out, or you'll start doing unusual things to protect yourself, maybe carrying a knife. Associations being made between things. So, the classic referential stuff, the referential delusions. So, that person was carrying a bag, and that bag meant that they were a spy, or looking at number plates and codes in number plates. This is all referential stuff. Or looking at the TV, and if they're watching a TV program, they say, that TV program was all about me. This is very much in the psychosis, schizophrenia presentation. So self-referential paranoia, thought echo withdrawal, insertion and broadcast, and thought disorder. If we've got those symptoms, then we can be on much firmer ground that this is actually psychosis. And other clues alongside the symptoms are functioning, which I've talked about. Functioning is key. If you've got psychosis, your functioning should have deteriorated. Likely had social withdrawal. Let's not forget, these are highly genetic conditions, and there probably should be something in the family history because they're 70 to 80% heritable. And there should be a lack of insight. If somebody's coming to you saying, I'm really concerned about the voice in my head, it's probably, chances are, it might not be psychosis, because they've already realized it's a voice that's not real, compared to somebody who's schizophrenia who says, my neighbors are talking about me. See the difference? There should be a lack of insight about their experiences. There's much more characteristic of psychosis. So this is a really complex space, and we need to hold uncertainty. And we have, in my team, an extended assessment pathway that can go up to 6 months, where we're unsure and we're assessing and we're watching. The problem is that people with borderline and ASD can respond a little bit to antipsychotics, but they don't get completely better, and they have another triggering episode and they're just back to square one again. If that happens, really think about the diagnosis and think about whether it is something else other than psychosis, because there is the idea that you can use antipsychotics to reduce arousal and mood stabilize a bit, isn't there? So actually, if in EUPD, so actually we've got to be careful not to just be reassured if there's a little bit of improvement. We want to see really good treatment impact of antipsychotics. So that's it. I hope you found that helpful, and we've got 5-10 minutes for questions. I'm happy to take any questions that you might have.
Sorry, sir, I'm a third year registrar. this is actually about the treatment aspects. Do you think there's a place for pharmacotherapy in prodrome of schizophrenia? Is there any novel evidence for that? And what about the ethical dilemma of treating patients in the prodromes? Because as we know that most of them won't progress into full-blown psychosis. I would like to know your view about that, sir.
Yeah, thank you for that question. There is no evidence for using antipsychotics in prodromal psychosis, so we shouldn't use them. But and also that can make diagnostic difficult. That can cause diagnostic difficulties later down the line as well. You need to treat the other problems that are presenting. So if they're depressed or anxious, use an SSRI and CBT. If they're not sleeping, use some hypnotics. Try and get them off any drugs or alcohol they might be using. So those are the treatments that I would suggest, but there's no evidence for antipsychotics in the prodromal state. So it'd be about watching and waiting and acting as soon as they do transition and starting an antipsychotic at that point. I saw another question in the chat about what do you have a preferred antipsychotic for FEP? Yes, we have two first line, which are aripiprazole and risperidone. Quetiapine is not first line because, first of all, it has lots of side effects of sedation and weight gain, but we also don't find it to be quite as effective, although the evidence does suggest equal efficacy. We don't tend to find that. But of course, if somebody's got a comorbid, perhaps EUPD, then we might think about it first line quetiapine, but generally it's aripiprazole and risperidone. Olanzapine is not first line because of the metabolic side effects. We use quite a lot of amisulpride. That's really good, obviously weight neutral. But the problem you get with that is the raised prolactin, which can be problematic for people. So, but aripiprazole is probably my first go-to. And if you can manage the akathisia, sometimes with a bit of mirtazapine, then if you do get the akathisia, then that's a fantastic drug because most people don't have any side effects with it. And you can often get away with just 5 or 10 milligrams in first episode of psychosis. So, often you've done them a really good favor by getting them onto that, and they don't have all the metabolic problems. Any other questions? Yeah, well, I do go up to 30, but if of aripiprazole, this is the question in the chat, what's the maximum dose of aripiprazole that you would use? So we do go up to 30, but my impression is that if you've got 15 or 20 milligrams and they've been on it for 8 to 10, 12 weeks, and there's still, partial treatment there, partial response, you're not really going to see much more benefit going up to 30 from 20. But I would always take a careful history. And if there has been very significant benefit from 15 up to 20, then I might try a higher dose. But usually what I find is that there might have been a minimal benefit at 5 and 10. And then going up to 15 and 20, there might not have been any benefit from those subsequent increases. That tends to be the pattern. And then I would look to switch to a different antipsychotic.
Hi, Daniel. Ashini.
Maximum dose for risperidone, we don't usually go above 4, just because that doesn't tend to be clinically effective, particularly in FEP. If you haven't got full therapeutic response from 4 milligrams, I would just switch. Hi, Suhashini.
Hi, Daniel. So I have a question. In Sri Lanka, patients have good access to mental health services. And I'm aware of your work on social prescribing and getting the family involved in disease processes and treatment. And what we see here is that the family tends to be very involved in patient care and in looking after patients and making sure that their compliance is on track. So do you think an early intervention, a separate specialized early intervention service in our country with very low resources, but still with good access to mental health services and family being so involved, will there be any added benefit in having a separate early intervention service?
Yeah, that's a great question, and I won't profess to be an expert about what Sri Lankan mental health care is like. But yes, as you've told me, there's a lot more family support. The benefits, I think, are really in assessment, in getting the assessment right. So often, I find in the UK, I will have been referred somebody who's been started on antipsychotic. They do not have psychosis. And then you're setting somebody up for a potential lifetime worth of treatment that just isn't warranted. And the other side of it is, so that's one problem. They might not have psychosis. The other problem is they're not spotted soon enough. So you can see we're between a rock and a hard place. You don't want to treat things that aren't psychosis, but you want to spot psychosis as quickly as possible. That's why there does, having a real expertise in assessing for psychosis, and it is an expertise that I find lots of psychiatrists and other teams just haven't developed. It is an advantage very much an advantage for patients, getting that diagnosis right. Prescribing, there is some expertise in first episode psychosis prescribing, but really it's not that different from general prescribing. You just don't use so much, and you need to be more assertive in watching response and changing and getting onto clozapine if necessary. So it's basically just a more assertive form of usual prescribing. There is a lot to be said for assertive working with this population to really make sure that they understand their condition. And in general services here in the UK, people are discharged quite quickly as soon as they're well. And the fact that we hold on to them for 3 years helps the patient realise that really, things are serious, but also helps them, put more work into perhaps understanding their problem and realising that there are solutions. So, yeah. Guys, I've probably got time for one more question because I've got something at past. So is there any final question?
If I might ask one last question, please, Dr. Maughan. I'm sorry if you've already said this, but how widespread are early intervention services in the UK?
Every locality in the UK has an early intervention service. In 2015, there was a government mandate that every locality should set up an early intervention service that is able to deliver those evidence-based interventions that I showed you at the beginning of my talk. So we don't always manage to deliver every single one of those interventions to every single patient because there are still resource constraints. But yes, every locality has an early intervention service.
Okay, I would like to thank Dr. Maughan on behalf of the college for the wonderful eye-opening lecture, and a big thank to Dr. Suhashini as well. So we'll wind up for today until we meet up in another interesting lecture like this. Good night, everyone.
Good night.